Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Randomized Trial of a Web-Based Intervention to Address Barriers to Clinical Trials by Meropol et al. My name is Jeremy Warner, and I am an Assistant Professor of Medicine and Biomedical Informatics at Vanderbilt University in Nashville, USA. My oncologic specialty is malignant lymphoid neoplasms. Cancer care has improved immeasurably for nearly all subtypes of malignancy over the past 50 years. The U.S. cancer patient population as a whole now has a median survival of more than 5 years from diagnosis for a disease that was once a near universal death sentence. For the most part, these gains have been incremental and are due to carefully planned and executed clinical trials. During this half-century of remarkable progress, thousands of trials enrolling hundreds of thousands of patients have informed a continually evolving standard of care. It is thus of concern to all practicing oncologists and their patients to hear the oft-repeated statistic that only 2 to 3% of adult cancer patients are enrolling in contemporary clinical trials. Large numbers of trials close prematurely due to accrual failure, and an untold number of trials are never launched in the first place. Many patients do not enroll for reasons beyond eligibility criteria, such as lack of access, insurance constraints, inconvenience, and cost. Thus, any intervention to improve clinical trial recruitment is noteworthy. In the article that accompanies this podcast, Meropol et al. Have evaluated a theory-guided, web-based interactive computer program entitled PREACT, Preparatory Education About Clinical Trials. This tool was iteratively developed by this group over a number of years, with an initial presentation at the NCI ASCO Cancer Trial Accrual Symposium in 2010. The current manuscript reports on the results of a prospective randomized clinical trial that was conducted at 4 NCI-designated comprehensive cancer centers, where the authors compared PREACT to a control condition that provided general clinical trials information produced by the NCI in plain text format. 6,878 cancer patients were screened for the trial and contacted by phone, with 37% verbally agreeing to participate. Most of the others failed screening due to an inability to contact the patient, although 1,291 explicitly declined to participate. Of the 2,568 patients who agreed, 49% provided electronic informed consent and were randomized. Randomization was stratified by study site and occurred before the initial visit with an oncologist. All participants underwent a baseline survey addressing knowledge, attitude, and preparation for consideration of clinical trial enrollment, which was repeated after the assigned intervention. The two groups were well matched by age, gender, tumor type, extent of disease, and race. Notably, half of the patients had non-metastatic disease at diagnosis. Breast cancer was the most common diagnosis, although many cancer types were represented. The baseline surveys revealed some interesting findings across both groups. For example, 75% of participants thought that most clinical trials involve a placebo, and 58% thought that standard treatments are never as good as new research treatments. 30% felt that clinical trials are best used for people with cancer that can't be treated any other way, and 5% admitted to not trusting doctors at all. After the interventions, there was a significant increase in knowledge in both groups, with the PREACT group having a greater incremental gain than the control group. Attitudinal barriers were slightly decreased in both groups, with again PREACT having a greater effect. Finally, both groups felt significantly more prepared to discuss clinical trial enrollment after the interventions, with no statistically significant comparative difference. In an exploratory analysis, the authors found that older age, female gender, greater than a high school education, and married partnered status all favored the pre-ACT intervention. Importantly, users of pre-ACT were more likely to feel that the length of the program was reasonable and to feel that the program was useful for making a treatment decision. In the 6 months following the intervention, 13% of the patients enrolled in a therapeutic clinical trial, with no difference in enrollment rate between the two arms. This important trial shows that knowledge, attitude, and preparedness can all be improved with web-based interventions. The control arm was an active arm, which may limit the generalizability of the study, although the control arm was found to be less user-friendly by its users. While it was not the primary outcome of the trial, 13% of patients subsequently enrolled in a therapeutic clinical trial. If one assumes that the patients who declined to participate at screening or did not complete informed consent would not have enrolled in any clinical trial, this number is closer to 4%. Although this is an improvement to the oft-quoted 2 to 3% enrollment rate, it is a very modest improvement and suggests that there are many more barriers to overcome. However, it should be noted that with half of the patients having non-metastatic disease at the time of enrollment, it is possible that there was a well-established standard of care approach in many cases. There are certain barriers to trial recruitment which are easier to overcome than others. As the authors note in their discussion of limitations, the population studied was biased towards white race, a higher educational level, and a higher socioeconomic status. Thus, it is unclear whether the intervention would improve enrollment across an unselected population, including those without a reliable home internet connection or with limited literacy skills. Notably, the latter population would be unlikely to benefit from the control intervention either, and those without internet would not have access to either intervention. Clinical trial recruitment is arguably the linchpin of a system that seeks to improve the outcome of all cancer patients, but there are other important considerations as well. One is trial eligibility criteria. It is no coincidence that the trial population has represented younger and healthier patients than the cancer population on the whole. Widespread restriction to patients with a good or excellent performance status, exclusion of the elderly, and stringent criteria excluding patients with a second malignancy have led to the inability for practicing oncologists to confidently extrapolate trial results to many of their patients. Accordingly, the clinical trial literature is surprisingly sparse on dose modification guidelines for renal and hepatic dysfunction, treatment in context of a second malignancy, and for age. An example of what will hopefully soon be the norm for dose modification guidance is the first trial for multiple myeloma, published by Ben Boaker et al. In the New England Journal of Medicine in 2014. Personalized dose modification should improve both toxicity and efficacy profiles, since the likelihood of an early treatment discontinuation for side effects would be expectedly lower. Equally important to the biases in planning and execution of clinical trials is the failure to publish results in a timely fashion, whether positive or negative. Tam et al. Addressed this issue in JCO in 2011 by surveying all Phase 3 trials presented in abstract or oral format at the 1989 to 2003 ASCO annual meetings. They found that nearly 10% of trials remained unpublished with a minimum of 6.5 years of follow-up, and that 71% of these had reported negative results. Furthermore, they judged that 70% of the unpublished trials addressed an important question, and 59% might have had a clinical impact had their results been published promptly. While many expected that mandatory publishing requirements introduced by clinicaltrials.gov would improve the rates of non-publication, a 2012 analysis in BMJ by Preparedness et al. Suggested this is not the case, with only 22% of trials complying with the requirement to report results within 1 year of completion. One can only hope that new impending regulations will approve this in short order. In conclusion, Meropol et al. Have presented a tool that has a demonstrated incremental improvement in knowledge, attitude, and preparedness to discuss clinical trial enrollment. Pre-ACT is available now through cancer.net for anyone to freely use. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.